covered sickle cell anemia. We did the anemia.
Stop. It's for thylacy. It starts with TH.
That's where we stopped?
Yeah.
Okay, so I was correct. So my memory still serves me good.
Yeah.
Okay, yeah. All right. So we did as part of that time we reviewed the blood components, the complete blood counts, the neutrophils, the erythrocytes, where those blood cells are manufactured, and we proceeded to define what happens when it's low or high, and we treated anemia in general, and then specifically iron deficiency anemia and sickle cell anemia. By definition, we know that anemia is anything that will result in what? What is anemia? How did we define anemia? No, don't treat iron, just anemia overview. How did we define anemia? What would happen that for us to say that it's an anemic presence, that it's anemia? What is it? What will happen? There is so what will happen with those red blood cells? How did we define anemia? Overview of anemia, and not regardless of what caused the anemia, regardless if it was nutritional deficiency or destruction of the red blood cells or it's iron deficiency or whatever. Timothy.
A critical low hemoglobin count. Anemia is considered a critically low hemoglobin count.
So what about that hemoglobin? How did we define anemia for this class? What did we say about that hemoglobin?
The inability for the body to efficiently distribute oxygen.
Look on your slides, guys. Come on, look on your slides. That's like the overview of anemia. What is it?
Most common symptoms.
Huh?
A result of decreased red blood cells or hemoglobin concentration that is below.
Okay. So once there is a decrease in that concentration of hemoglobin, regardless of what is causing it, we define it as anemia. Okay, what is the function of that hemoglobin? Huh? Hemoglobin, so once there is a condition that results in the blood cells' inability to carry oxygen and nutrients to the tissues, that is anemia. Okay, so we looked at different types of anemia, what can cause it, and that would be what? Nutritional deficiency, what else? Blood loss, what else?
Iron deficiency.
Iron deficiency, okay. We'll categorize it as nutritional. What else?
Dysfunction marrow.
Marrow dysfunction, where there is a suppression of the bone marrow system, or where.
Decreased red blood cells.
Okay, what is that? Say this function of that red blood cell that will suppress it so you are not producing enough red blood cells. or when there is excessive destruction, as you see. Okay. So we highlighted iron deficiency anemia, and we said that in that instance there is not enough iron to help make the blood cells, and there, we have two ones that is a deficiency we need to replace. So what is the special considerations when we are giving iron for a child?
Vitamin C.
Huh?
Yeah.
What about vitamin C?
But you have to give it with iron.
Okay, and why do we need to do it?
It helps with absorption.
Okay. All right. What else do we need to do with iron? What else is important with iron? Okay, but you are trying to treat the deficiency. Why during the treatment?
Monitor it.
During the treatment. So what do you need to do? What teaching do you need to give?
Increase fiber.
What else? Fluid. What else? Okay. What else?
What did you say? It's gonna be dark still.
So we pull that. Now, with your sickle cell anemia, what is sickle cell anemia? Huh? Where would we characterize? Why would we place that? Is it as a result of excessive destruction or a deficiency, or there is not enough? What is it?
It's a recessive trait.
It's pretty much the hemoglobin of the red blood cell. It's functioning abnormally, so it causes the red blood cell to become sickle shaped, which causes all the blockages and decreased perfusion.
Okay, in other words, there is destruction of those red blood cells by virtue of it being abnormal. That is a substitution of that violin in that molecular chain, making that molecule very unstable. Once it's unstable, the shape is sickled, and the lifespan of the red blood cells is diminished. Okay, so it's constantly destroyed, and what happens, the patient will become anemic. All right, so what is the primary treatment?
Blood transfusion.
For blood transfusion. Not all of them get blood, yeah, they will get blood transfusion eventually, but what will be our first line treatment? Primary treatment. Huh?
Like the nutritional treatment.
No, okay, but what will be our primary treatment for sickle cell anemia?
Pain management.
Pain management and what else?
Oxygen.
What will you instruct the parents to do at home when they fluid hydration, pain management will be the two primary things that you do for this patient. Because remember, the sickle cell is abnormally shaped and it will clog the capillaries, and with that, in the face of dehydration, that it won't be able to flow through the capillaries. And once it stops, the body will just translate that as pain. Okay, so you see that as pain, so you need to hydrate them, and you need to also give them pain medication. All right. So, and that's an inherited disorder. And how is it inherited? One parent will have the disease for you to transmit it? Not quite.
No, each parent has a trait of the sickle, and then you
Okay. So sickle cell anemia will refer to sickle cell anemia as a recessive trait, meaning that the abnormal gene will have to come from one of the parents. The child will receive one abnormal gene from each of the parents in order for the child to express with the disease. If the child is receiving just one abnormal gene,
That's carrier.
that would be a carrier. Okay. So thalassemia is another form of recessive gene in that both parents, like in sickle cell anemia, will have the abnormal gene. Okay, so there are types of thalassemia. Thalassemia alpha, which affects the alpha chain, and the thalassemia beta. These two thalassemias, they are occur, but the ones that we see all of them, but the ones that you see most commonly will be the thalassemia A alpha. And it has the same features, the same characteristics of sickle cell anemia in the sense that you result in destruction of red blood cells, and the treatment is also, maintaining that life by giving them blood transfusion. Yes.
It says that beta thalassemia is the most common. Next slide, please.
Yeah, thalassemia B, yeah, the most common. But the other ones, A, you will see that, but the B is the one that is most common, and that's the one that you see in our area. You will have 4 types of it, the minor and major. Minor ones, your patient is asymptomatic, they are basically like a carrier. And then the major one, that's the one that goes into severe anemia, and that will require blood transfusion for the person to survive. If you the area we're in what is it, Staten Island, where you have a concentration of Greek individuals, you see a lot of high patients with thalassemia around that area. But note that these days, with advances in genomics and identification of all these minor characteristics of all these genetic conditions and intermarriages, you see that all these conditions that we say is predominantly in this particular age ethnic group, is now across the board for everybody. So you will not be surprised if you see thalassemia in a Caucasian patient or any other patient for that matter. So, because of that increase in destruction of red blood cells in that hypoxic event that happens, the patient is constantly anemic and there is low tissue oxygen. Note the difference between hypoxia and hypoxemia, because you may be asked, the question will be posed to you to identify which one. Hypoxia is tissue, hypoxemia is in the blood. So you have to just remember the two. Okay? And with that chronic thing, you'll have irritability and all these kind of symptoms that you will notice. Patients will be severely anemic. And you notice that failure to thrive, the FTT, failure to thrive. And there may be enlargement of the spleen. So, diagnosis of thalassemia is done by erythrocyte hemoglobin erythrophoresis. They'll take the hemoglobin and just take this, put the smear on the slide and look at the picture on the slide. Often you will notice that as early as 6 weeks of age. In sickle cell anemia, we do the PKU screening, identify those patients, from that newborn screening. And then to confirm the diagnosis, we still do the hemoglobin erythropoiesis. So management here will be, we'll give blood transfusion for this individual. As opposed to sickle cell anemia, our first line of action would be to hydrate the individual and to give pain management. In this case, especially with severe thalassemia major, our first line treatment will be blood transfusion. And then if you are giving that constant blood transfusion, you have to be very, very concerned about iron overload, in the sense that this person, number one, is destroying their red blood cells, and the byproduct of the red blood cell is the heme and globin. Heme is the iron, globin is the bilirubin, which you will see as that tinge color on the skin. So they have excess iron from that destruction, and in addition, we are giving iron through blood transfusion. So we need to monitor them very carefully. And once there is any slightest indication of iron overload, or we need to give the distillation agent, and that's why most of those patients are expert. Even if some patients with sickle cell anemia, they get expert as part of the treatment, because we need to bring down the level of iron. Okay? And again, the nursing care will subscribe of the following. Well, because of that constant decrease in blood, they may have delays in developing the secondary health characteristics. But again, ultimate treatment would be bone marrow transplant, as well as the same case as with sickle cell anemia. They have cured the full bone marrow transplant. But again, you have to weigh the complications that can stem from bone marrow transplant and the actual constant blood transfusion. Most often, when there is a good match, a perfect match between the donor and the recipient, they opt for this bone marrow transplant, and some of them that have done, they're successful. So moving on, any question on thalassemia? If you just remember in thalassemia and sickle cell anemia what you need to do to maintain that life, sickle cell hydration and pain management, and thalassemia, you have blood transfusion, and sickle cell, you get blood transfusion also, and what you need to monitor for when you give blood, we did cover that to a greater extent the first day, and then you will be fine. Okay. Lead poisoning is another thing that can cause anemia. Because all the things we've talked about right now can lead to decrease in red blood cells circulating in the system. Another thing that can cause that would be anemia, would be presence of lead in the blood. What the lead will do is to displace the hemoglobin. Once the hemoglobin is displaced and you replace it with lead, there is a diminished. So the hemoglobin now is mixed up with lead, and the lead is what is getting circulating in the body. Okay. How do we acquire lead? Of course, with old paint. Thank God they just, they did the regulations that no more lead in the paint, no more lead-based paint in the market. But one thing that still bothers me is that you see these toy machines that they put like a quarter to get a small toy. Most of those toys still contain lead. They will import them cheaply from China and put them in those machines. And those are very attractive to children, so they'll take it, they put it in their mouth, and that's because they are increasing lead. So what they are doing now is that sometimes they will get them on the wharf and seize those things, but some of them still make their way into the market and out there for them to play with. Other things, other sources would be from, if they live in an old apartment with cheap, paint, dust, that can also lead to that. So what happens is that with that lead, taking place, displacing the hemoglobin, it leads to anemia, and that lead also can destroy the renal system, or it can lead, once that is increased, once it's lodged in the neurologic system, it can also lead to increase in intracranial pressure, or even ischemia when it blocks the flow of blood to the cerebral vessel, or when there is not enough oxygen to the red blood cells, so that can lead to ischemia. So what do we do? Our primary thing with lead would be to identify the source and eliminate the source. So for children, when they come to the clinic, starting from 6 months of age, as you do their CBC, you also do the lead screening. They do it at 2 years, and they'll do it, so once they come for their routine blood work, we will do that as part of it. And once the child is identified as potentially lead in their blood, then you have to screen that child. For any level less than 10, you just don't do anything because but once it's above 10 and up to 15, usually they will look at the child's home, inspect the home, inspect the daycare center where the child is going to, or any areas where the child could be exposed to lead. But once that level is above 20, I see this is that they are, they have to be aggressive and just identify that patient, including the siblings and everybody. Treatment will start with chelation agent when the level is above. CDC would say above 40, but we are doing defensive medicine, so we start at a lower number because we would really like to monitor those patients. Once they take that chelation agent, the first line will be the PO, Chemit, or Sokima, and they'll take it PO. And it is important for any patient taking the chelation agent for you to monitor the renal system. So you need to monitor the urine output, you need to monitor the urine specific gravity, because these medications are excreted via urine, and you need to monitor that paragraph. Calcium disodium can be given, or the British anti-lumin can be given, iron. Just when you cannot give the IV diamond. Okay? The IM is so painful, and you have to do a Z-track because it's just oil based. And I believe they have, I don't remember quite correctly, I think they have now a newer form of it that is, can be given IV. So, but the IM one is, will be your last resort. And in any case, you need to monitor the patient very carefully. And again, you want to prevent lead exposure. So another inherited condition, yes,
Sorry, so the dimer is the IV, and then, is that what you were saying?
that's an IV part of it, yes. But your first time will be to give the PO, one, which you can give with food or mix in a food and give or in a drink that you try to be safe. And then you have to monitor the type very closely.
So would you rather give the IM one before the IV one too?
Why would you give the IM one before the IV? I just said to you that the IM one will be your last resort.
Okay, no, that's what I'm saying, I was confused as to which one you were saying was the last one, okay.
IM one will be more painful for the time because you don't want to be taking that child every day to give that, and it's oil based. You have to do a Z-trap and it's more painful, more invasive. So we start with the least invasive one, which is the PO one, and then if necessary, do the IV one or the IM one as a last resort. Any more questions? Hemophilia, it's another heritage blood disease disorder, and this one is as a result of deficiency of the clotting factor. So we have hemophilia A, which is referred to as classic hemophilia, where you have deficiency in factor A. And then you have the hemophilia B, which is also referred to as Christmas disease, where you have a deficiency in factor 9. All these factors, factor 8 and factor 9, help in the coagulation of blood. Now, hemophilia we know as a sex-linked recessive trait. One, the defect has to come from both parents. However, because it's sex-linked, it's only, the defect is only on the X chromosome. Originally, we know it as hemophilia will only affect the males, and the females are only the carriers. However, these days, there are female hemophilia that have been documented in the literature. So, for the general purpose of this, we say that it's only on the X chromosome, which every, the female is the XY, their Y is almost always consistently, okay, there is no problem. But when they inherit the X chromosome that is defective from their mom, then they'll have the disease. The mom, on the other hand, can inherit a good X chromosome from the father that is healthy and normal, and then a defective X from the mom, and that person will be a carrier. However, when it flips, that the X chromosome that the person is inheriting from their dad is the defective X that their dad had, because dad has only one X. When that is a hemophilia, that dad is capable of giving that defective X to the female, and then if the mom is the carrier, she can also get the defective X from mom, and that will define her as a hemophilia, which have been documented recently. Okay? So what happens now is that there is bleeding, and that will also depend on the amount of clotting factor and the severity of the injury that happens. So most of these patients, some of them will have majority of them will have family history of the hemophilia, but there are still others that have no family history of hemophilia, which have been lumped in as those with gene mutation. So this is what I was trying to explain to you. This mom here is supposed to be a carrier here, and this dad has this X that is defective. So that's their transmission. However, if a child, which I don't have here, have inherit this X that is defective from the dad and inherit this X that is defective from the mom, that will make that person feel like that's what is going on these days. So what happens is that there is bleeding tendency, which may become very severe. And that bleeding is really what causes the problem, especially when there is bleeding inside the joint. Once there is bleeding inside the joint, that now serves as a foreign body inside that joint, and that will prevent that person from moving their joints, and that will cause that disability or inability to use that area. It could be bleeding in the knee, it could be bleeding in the more commonly in the joint. Other things they can do, they can bleed from their nose, or they can have echymosis easily. Men transferring them from the stretcher to the bed, or if you are roughly handling them, can cause bruises. Okay? Again, for a child that is anything surgery or circumcision, also they can bruise and bruise and bruise and bruise and bleed for so long. So the diagnosis, this can be diagnosed in utero, or when you do the lab, you'll be able to identify factors 8 and 9 or 9 that are low, and that is prolonged the prothrombin time. So, treatment, of course, we identify which factor is missing and we need to replace that factor. And then we'll have to give desmopressin, which you will also see consistently as written as DDAVP, that will be given IV, and that will cause the increase of factor 8. Okay? Transfusion can be given also, and these transfusions, they receive it, and in some cases you see them replacing the factors at home with their infusion nurse present. But in some cases, in some centers where they have now, they have the day hospital, as you will see in the hematology clinic at St. Joe's. So the patient will just come there and they'll run the whole factor or the blood. Again, you have to put in place your bleeding precautions for the patient, and you need to educate the patient and support them. So, when there is that blood inside the joint, that causes a lot of pain. We need to immobilize and elevate that joint. artificially, and you need to apply ice. Once the bleeding stops, you need to gently resume range of motion exercises because we would like to prevent contraction. Because that patient is not moving that arm, and over time it will cause a disuse in that arm. You would like to give an analgesic, but you would like to give nothing that contains aspirin. Okay? This is another form of hereditary thing that can cause bleeding. What this does is the bleeding disorder. This one is an autosomal dominant, which means that only one parent can have the defective gene for the child to get it. Okay. So what happens, it causes a lot of bruising. There is peristaltic bleeding from the nose, or excessive bleeding during menstruation. Again, when you do the blood work, you are able to identify the von Willebrand factor level that is low, and also the platelet is decreased. Okay, so that's your characteristics for this. Now, because this patient will present with bruises, again, you have to be careful when you are, because they bleed, and you have to identify those patients, and you need to use your DDAVP as you would in hemophilia. Again, you need to avoid your aspirin. And again, you need to kind of note those patients well before you say it. Yeah, I see all these bruises all over the body. The mom is abusing the parent, the child. Okay. Another one would be the idiopathic thrombocytopenia. With this, you have excessive destruction of the platelets that reduces the platelet count to less than 20,000. Normally, you will want to exceed platelet count anywhere around 100,000 and above. 120 would be your ideal, but for some reason there is excessive destruction and it's low, and with that, that person is prone to bruises. You see those tiny, tiny bruises on the skin that we will refer to as petechia. And this condition, destruction of the red blood of the platelet count, will follow upper respiratory tract infection. Any kind of viral infection, could be measles, it could be just flu, it could be anything that is viral in origin. The child can, following that viral exposure, can come down with, can have the platelet count destroyed. Okay, once that happens, over time, the acute form will be self-limiting, but however, when it progresses, it prolongs for so long, it becomes chronic, in the sense that the platelet count is constantly low. And when that is constantly low, then that's the time you start worrying, because you need to bring that platelet count, and with the platelet count is low, that child cannot do contact sports. Okay. So what you would like to do is to give immunoglobulin when the platelet count is less than 20,000. And once it's more than 20, then you can give corticosteroid, EO, and they may take this over a long period of time. So again, we'll have to do all our bleeding precautions, including avoiding contact spots and avoiding aspirin and iron injections also. done all those things that can lead to anemia and or destruction of the blood cells. We looked at anemia, iron deficiency anemia, sickle cell anemia. We looked at our hemophilia, and we looked at ITP. Of all these, ITP will be the one that is acquired. The other ones are all inherited disorders. Okay. So, looking at the cancers, we look at the cancers in children and in adults, and we say that the pediatric cancers arise from, during cell development. Okay, so once there is that abnormality in cell development, then you have it as cancer or we have the leukemia that results from the blood cell development in the bone marrow. But in adults, their cancers are from the epithelial cells, but in children, they are from development, embryonic development. That would be the big differences between those two. So with leukemia, we define our leukemia as a form of neoplasm or a form of cancer, but it affects the tissue that produces blood cells, white blood cells. So once that is happening in the bone marrow, for some reason the white blood cells during development will just start to replicate itself. And with so doing, there are too many white blood cells. Yes, there are many, but they are just immature and non-functional. Because there are so many in there, remember the other blood cells, like the red blood cells, like the thrombocytes, everything is also manufactured in the bone marrow. But the white blood cells are too many, too numerous, that they suppress the production of the other kinds of blood cells. So that makes those other cells very low. Okay, so leukemia, we'll say, is the most common childhood cancer. And the peak onset age is between 2 and 6 years of age. So again, the white blood cells, non-functional, cannot do anything, but they just suppress every type of cell in the body, leading to all the problems that they have. So the diagnosis of this is the ability to identify those immature red blood cells. You do the bone marrow aspiration, look at it under the slide, and you'll be able to see that these are all immature red blood cells. Or when you do the blood work, you look at it, you see a very low count, and you see all these numerous white, immature cells, the blastoclast class. So you confirm your diagnosis. Confirmation of the diagnosis is on bone marrow transplant and aspiration, where you have evidence of 25% or more of these new immature blood cells that we refer to as blast cells. Once you have more than 25% of it, that will confirm your diagnosis. And then you look at closely examine the cells again to identify which type they are. So, looking at the types they are, we have two major types in children. We have the acute lymphoid leukemia, and we have the acute non-lymphoid leukemia. So the first one we're looking at here will be the acute lymphoid leukemia. which will describe as the most common type of leukemia or cancer in children with the peak age of 2 to 10 years of age. This type of cancer, the acute lymphoid leukemia, children will achieve their first remission, meaning that they will be with proper treatment, chemotherapy, and or with radiation therapy, they will become cancer-free, and they can live. They can become cancer-free. Some of them more than 5 years. Okay. However, their problem would be infection will be the most common complication that will kill them. Meaning that the white blood cells, yes, they are numerous, but they are non-functional and cannot fight infection. And the neutrophils are non-existent, so any slightest infection can just wipe the person out. So, what is the clinical signs you see the patient will become anemic? All the signs and symptoms of anemia will be present because all the blood cells are diminished, suppressed or diminished, and the patient can have low-grade fever. Okay. Once that white blood cells, numerous white blood cells that is circulating gets into the joint, and the bones are so congested, so tight, the way the brain will refer to that will be as pain, and they will say, oh, I have tightness here, and there is pain in my leg. So that's what they are. You see a slight swelling, the area will feel warm to touch, and then the patient will complain of pain, or you notice that the child is not using that particular extremity. And that's what will bring them to the hospital. And then upon investigation, then they'll come up with the diagnosis. Okay. So another thing that may happen is that for that patient, if those leukemic cells can migrate to the central nervous system and clog the capillaries over there, again, that congestion can lead to increase in tension that the body will refer to as headache. Okay, depending on how severe it is, the patient will start having alteration in mental status, including unsteady gait, including blocking the path of flow of the cerebrospinal fluid, leading to accumulation of that fluid and swelling of the head, and what we will all notice as or refer to as hydro. So, on the other hand, the acute non-lymphoid leukemia, the annual, this annual is 25% of childhood leukemia. Of this non-lymphoid tissue, we have a sub characteristic of it, a sub character of it that will be the acute myelogenous leukemia, which is also a form of non-lymphoid because it does not originate from the lymphoid tissue. Okay, so this acute myelogenous leukemia it's 20% of all the leukemia that you will see. But non-lymphoid is 25% of everything, but myelogenous will be that plus the with that and the lymphoid tissue. This particular myelogenous is common in adolescents. The acute lymphocytic, we said, is common in children, younger children, 2 to 10 years of age, but this one is just with the adolescent. Another difference between this one and the all is that this one is harder for the patient to achieve remission. Okay? So it's harder for them to achieve remission. The same, all signs and symptoms that you will see in acute lymphocytic leukemia will be present in this. But however, they have a hard time achieving a remission. Diagnosis is the same, still with bone marrow aspiration and biopsy. And again, they can succumb to infection, especially respiratory infection. So treatment for all types of leukemia would be chemotherapy agent and or radiation therapy, but chemotherapy will be the primary thing they will use. They'll put a central line and then infuse the agent. And they will have to do it in phases. Phase 1 will be their active infusion of chemo agent that usually will last 3 to 4 weeks. After which they'll have to do their, do their investigation that the patient will have to come in on certain days that they will tell them, weeks or months interval that they will come. And then they will have to do their maintenance. But during that active induction, that first 3 to 4 weeks, that patient needs to be an inpatient. Because you cannot afford to do that as an outpatient. The other ones you can do as outpatient. Another thing that happens also with giving them the chemotherapy is that the chemotherapy agent that is infused through the central line does not cross the blood-brain barrier. For some reason, it will go to all the other places, but the blood-brain barrier does not cross it. So, for them to treat the ones that potentially increase the leukemic cells that might potentially have gone to the brain to take a hideout, they have to do a spinal tap, insert the intrathecal catheter, which is like instead of putting a central line here, they'll put central line through that spinal tap and leave that tubing, the Omeyer valve reservoir or the intrathecal catheter there, and then infuse the chemotherapy through that route. And this is the one that goes into the central nervous system area and attack the leukemic cells that are potentially there. Yes, Debbie.
You said, but that's what that intrathecal.
Yes. It's inserted, it's like instead of putting a PICC line through the cephalic brachial here, you don't do it. You will do it through the spinal cord and inside the tubing, and then infuse the chemo agent through there. And that is the only one that can cross the blood-brain barrier. Anything you give through the central line, it will go there, kill the ones in the bloodstream and the marrow and all that, but not the ones in the brain, so they would like to attack those ones also. So it's important that you know that they will do it, to attack those ones. Otherwise, the patient can come down with some kind of cells there that have migrated to that place, and you ended up getting rid of all the cells, leukemic cells, but the ones in the hideout, and then blood will carry them again and put them back into the system. So again, infection control is a primary thing. These patients have, they don't have blood, they lack all the blood components. They can bleed easily, and they are prone to infection. So we do not do rectal temperature In fact, rectal temperatures in a child, we don't do it unless it is absolutely important. More so in patients with leukemia, no rectal temperatures. Okay? So, and then we'd like to put in place all these other stuff here. Again, things that can happen, infection because of that neutropenia, they can bleed, they can have anemia, they can have nausea and vomiting. Okay, all these are things that can happen to them. Another thing that we need to warn the patients, no matter how little they are, is that once they start receiving that chemotherapy agent, their hair will fall off. I mean, I will never forget one of our young patients. We had this child and we gave chemo. None of us told this baby, this child, that her hair will fall off. So she woke up one morning, her whole hair was on the bed. Oh Lord, this child cried and cried and cried. We were like, and I said to that, that is something that will escape everybody's mind. Yeah, and we were thinking that, oh yeah, that's a little child, it won't affect her. But no, it will affect anybody. Once you wake up and do like this, the whole head is on your bed. So you just have to remember to tell them that in addition to every other thing you have to tell them to do. Okay. This again comes with your chemotherapy agents. They can have bloody and painful urination. And to treat that, we must make sure that we hydrate them very well, as we would when they are receiving their chemotherapy. Okay. Stem cell transplant can be done with for the leukemia and also for your sickle cell anemia. In fact, as a matter of fact, for them to use the stem cell to treat sickle cell anemia started with one of the patients in California that had leukemia and was also a sickle cell patient. So they did the transplant for the leukemia, and post-procedure, her sickle cell anemia was cured. So they started doing it as experimental procedure which they are now doing in some centers. I know Hackensack does it because I know Hackensack did it like 10 years ago, and they're still doing it. Dr. Gillo, so they still do it over there. But again, the risk of mobility and mortality is very high. But again, you have to kind of monitor the patient, monitor the rejection, and also monitor for infection, because that's really what will kill them. Okay. And this one we did with the wound tumor, we did it when we did that kidneys. Okay. So that concludes that lecture on immune system. We can take our break, and when we come back, we'll tackle this infectious control. Yeah. So take a break, and then we'll talk with infectious diseases, and then at the end of it, we will have to look at